I use a different.
We have a question in the back.
Not a question, just a comment. Warrenberg from Stockholm. I think phenoxybenzoamine should be put in the museum nowadays. We abandoned that drug over 10 years ago. When the availability was going down, we had to have license and so on. So we chose to change the doxazosin. And we have been using that in combination with the hydropyridine calcium antagonists, which act on another level. So you, with a double blockade, you can protect the smooth muscle from contracting from overload of catecholamines. And with that combination, we could have low doses of doxazosin, and we have reduced the time in the intensive care unit after surgery with 2/3. And we have no long hypotensive girls that when you drive them with more adrenaline infusion for 24 hours so for coming up in pressure. So I think it's time to put this ancient drug in the museum as phentolamine, which is a very dangerous drug to use in the theater. Nowadays, a steniologist has rapid-acting beta blockers as esmolol. This is minutes having effect and going off effect, and magnesium sulfate, adenosine, also with minute active effects. So in the theater experience, anesthesiologist, I think, doesn't need a preoperative alpha neither if he's very experienced. I think they manage very well. We have seen that in the intracoronary unit when we have an unexpected pheochromocytoma that's starting going up and down in pressure when you do cardiac surgery. When the anesthesiologists react, they can control that. And afterwards we diagnose pheochromocytoma. So that's not unusual that it's expected during some surgical procedures that get the pressure going up and down, but the anesthesiologists today can manage that, and we're not having any death in that outcome either.
There's a young lady in the back who's been waiting.
Thank you for the young lady here. Mark, I work as a clinical geneticist, and what I missed in the discussion up till now is the fact how we should screen the healthy individuals in SDH carriers, for example. Because we were talking about all the patients with already PGL and Pheo, but how should we do the screening in the healthy individuals?
The carriers? Yeah. They are healthy.
For example, sisters of patients and carriers of a genetic mutation. How should we screen them? For example, we advise to do once in 3 years an MRI, but how far do you go in the healthy persons?
We have, of course, have a basic screen with. It depends also on the type of mutation. Having in SDHX mutations. Of course, you have to screen the head and neck region for the head and neck gangliomas, which are the
how many times per? Once per 3 years, once per?
Once. How often you mean?
How often? And when to start? At what age do we have to start with?
Biochemistry or imaging?
Yeah, you have
follow up for a healthy person.
You should have lab results, of course, MRI of head and neck, and
ladies first.
Yeah.
Thank you. We have performed the PGL study for this to answer to this question, and after analyze more than 100 relatives, our conclusion are to perform for the first screening an MRI of the head and neck, a CT scan and an X-ray scan in France in order to detect the thoracic paraganglioma, because in routine practice the thoracic paraganglioma can be missed by radiologists, not non-experts. We recommend to send the patient to an expert center, And after that, if the screening is negative, we would like to have a biochemical analysis yearly, and all the 3 years, we propose to perform screening only by imagery and only by RMI head and neck, RMI of thorax, and abdomen and pelvis.
And
That's
what
all.
age do you start?
At the time of the identification of the mutation.
Okay, but even on young age.
If it is a children, you have to replace the CT scan by your RMI.
I just wanted to say, you know, if somebody has a genetic mutation, especially for the SDHX, and maybe you would like to know what would happen with children. And we usually test them at the age of 5. What we do only biochemical testing. And because we have already, you know, some children that they will start with tumors at age 5. But to do the imaging studies, because the load of radiation, we usually start at age about 7 or 8, and we usually prefer MRI over the CT scan. And we are very careful to combine it with very good biochemistry as well as measuring the chromocranial A. So there are no guidelines, and it will a little bit take time to get the guidelines for pediatric patients, but I think seems to me a little bit reasonable. Yes, methoxytyramine, but the methoxytyramine, you know, it's still a little bit complicated because it's not available, but sooner or later we will be also incorporating methoxytyramine, especially those children, they have a SDHX.
Thank you, Dr. Patzak. Dr.
Yes, I can give you a part of those. If we can go to a slide.
And this will be the last. I know we're over. My apologies.
This is the most challenging situation, which is this SDHB carrier, because we have a combination of conflicting arguments. One is high risk of malignancy, so we are afraid for that. The second point is low age of onset, but in the meantime we have a low penetrance, so this is a very good big problem. And if I can, I will show you, I'm joking, the solution of the contour. We just take a picture. This young lady, at the age of 25, has a swallowing in the neck. You can see, I think, easily. Then at the age of 30 years, the neck is very large and maybe bilaterally. At the age of 55, you will see very easily enlargement of the neck, bilateral enlargement of the neck. At the age of 56, later, MS is later. Then at the age of 68, now at the age of 74. So just take a picture, you will fall off. No, I'm joking, but it also, I think it's something interesting. We get this kind of picture in the Trento Valley to say that how we have to treat this has not been treated. And also, this is 183 male with that kind of mass in the neck. It was a carrier of SDHB, and we don't know the diagnosis, but possibly is a paraganglioma that spent a life normally and died for other reasons. So I think that's an interesting point. But to be real, this is a young man with a very large mass, so it's completely different. So I think that the treatment, I'm going back to that point, is a completely open question in the neck problem.
Thank you. Thank you kindly. Dr. Manger, I know we're
late,
over.
but anyway, I was just going to say, to get back to treatment with alpha blockers, I think if you have a person with metastatic pheochromocytoma and there's a long lifespan there, you ought to really use tyrosine also. The reason for that is that you want to decrease the synthesis of catecholamines, because I think high catecholamines can cause cardiopathy and all sorts of things. So I think you ought to knock off as much as you can the catecholamines in addition to controlling the blood pressure. Phenoxybenzamine is still a good drug.
Thank you very much, everybody. We can continue the discussion during the break. Thank you. I'm sorry for the questions we didn't get to. Thank you.